From stern guidance from the health minister and the surprising fact that in numerous locations around the country, the local council is leafleting people's houses, street by street, to come and get tested. The bottom line is that it is reasonable to expect the prevalence of the virus to be close to the number found by ONS, because they sample randomly, and would pick up symptomatic and asymptomatic people in proportion to their presence in the community. As of the most recent ONS survey, to a first approximation, the virus was found in 1 in every 1,000 people. This can also be written as 0.1%. So when all these 10,000 people are tested in Pillar 2, you'd expect 10 true positives to be found. False negatives can be an issue when the virus is very common, but in this community setting, it is statistically unimportant, and so I have chosen to ignore it. Better to focus only on false positives. So, what is the false positive rate of testing in Pillar 2? For months, this has been a concern. It appears that it isn't known, even though, as I've mentioned, you absolutely need to know it in order to work out whether the diagnostic test has any value. What do we know about the false positive rate? Well, we do know that the government's own scientists were very concerned about it, and a report on this problem was sent to SAGE dated the 3rd of June 2020. I quote, "Unless we understand the operational false positive rate of the UK's RT-PCR testing system, we risk overestimating the COVID-19 incidence, the demand on track and trace, and the extent of asymptomatic infection." In that same report, the authors helpfully listed the lowest to highest false positive rate of dozens of tests using the same technology. The lowest value for false positive rate was 0.8%. Allow me to explain the impact of a false positive rate of 0.8% on Pillar 2. We return to our 10,000 people who've volunteered to get tested, and the expected 10 with virus, 0.1% prevalence, or 1,000, have been identified by the PCR test. But now we've to calculate how many false positives are to accompanying them. The shocking answer is 80. 80 is 0.8% of 10,000. That's how many false positives you'd get every time you were to use a Pillar 2 test on a group of that size. The effect of this is, in this example, where 10,000 people have been tested in Pillar 2, could be summarized in a headline like this: 90 new cases were identified today, 10 real positive cases and 80 false positives. But we know this is wildly incorrect. Unknown to the poor technician, there were in this example only 10 real cases. 80 did not even have a piece of viral RNA in their sample. They are really false positives. I'm going to explain how bad this is another way. Back to diagnostics. If you'd submitted to a test and it was positive, you'd expect the doctor to tell you that you had a disease, whatever it was testing for. Usually, though, they'll answer a slightly different question. If the patient is positive in this test, what is the probability they have the disease? Typically, for a good diagnostic test, the doctor will be able to say something like 95%, and they can live with that. You might take a different, confirmatory test if the result was very serious, like cancer. But in our Pillar 2 example, what is the probability a person testing positive in Pillar 2 actually has COVID-19? The awful answer is 11%. 10 divided by 80 plus 10. The test exaggerates the number of COVID-19 cases by almost tenfold. 90 divided by 10. Scared yet? That daily picture they show you, with the cases climbing up on the right-hand side, it's horribly exaggerated. It's not a mistake, as I shall show. Earlier in the summer, the ONS showed the virus prevalence was a little lower, 1 in 2,000 or 0.05%. That doesn't sound much of a difference, but it is. Now the Pillar 2 test will find half as many real cases from our notional 10,000 volunteers, so 5 real cases. But the flaw in the test means it will still find 80 false positives, 0.8% of 10,000. So it's even worse. The headline would be 85 new cases identified today, but now the probability a person testing positive has the virus is an absurdly low 6%. 5 divided by 80 plus 5. Earlier in the summer, this same test exaggerated the number of COVID-19 cases by 17-fold. 85 divided by 5. It's so easy to generate an apparently large epidemic this way. Just ignore the problem of false positives. Pretend it's 0. But it is never 0. This test is fatally flawed and must immediately be withdrawn and never used again in this setting unless shown to be fixed. The examples I gave are very close to what is actually happening every day as you read this. I'm bound to ask, did Mr. Hancock know of this fatal flaw? Did he know of the effects it would inevitably have, and is still having, not only on the reported caseload, but the nation's state of anxiety? I'd love to believe it is all an innocent mistake. If it was, though, he'd have to resign over sheer incompetence. But is it? We know that internal scientists wrote to Sage, in terms, and, surely, this short but shocking warning document would have been drawn to the health secretary's attention. If that was the only bit of evidence, you might be inclined to give him the benefit of the doubt. But the evidence grows more damning. Recently, I published with my co-authors a short position paper. I don't think by then, a month ago or so, the penny had quite dropped with me, and I'm an experienced biomedical research scientist, used to dealing with complex datasets and probabilities. On the 11th of September 2020, I was a guest on Julia Hartley Brewer's talk radio show. Among other things, I called upon Mr. Hancock to release the evidence underscoring his confidence in and planning for the second wave. This evidence has not yet been shown to the public by anyone. I also demanded he disclose the operational false positive rate in Pillar 2 testing. On the 16th of September, I was back on Julia's show and this time focused on the false positive rate issue, 1M45's 2 minutes 30s. I had read Carl Hennigan's analysis showing that even if the false positive rate was as low as 0.1%, 8 times lower than any similar test, it still yields a majority of false positives. So, my critique doesn't fall if the actual false positive rate is lower than my assumed 0.8%. On the 18th of September, Mr. Hancock again appeared, as often he does, on Julia Hartley Brewer's show. Julia asked him directly 1 minute 50s on what the false positive rate in Pillar 2 is. Mr. Hancock said it's under 1%. Julia again asked him exactly what it was, and did he even know it? He didn't answer that, but then said it means that, for all the positive cases, the likelihood of one being a false positive is very small. That is a seriously misleading statement as it is incorrect. The likelihood of an apparently positive case being a false positive is between 89–94%, or near certainty. Of note, even when ONS was recording its lowest ever prevalence, the positive rate in Pillar 2 testing never fell below 0.8%. It gets worse for the health secretary. On September the 17th, I believe, Mr. Hancock took a question from Sir Desmond Swain about false positives. It is clear that Sir Desmond is asking about Pillar 2. Mr. Hancock replied, "I like my right honourable friend very much and I wish it were true. The reason we have surveillance testing, done by ONS, is to ensure that we're constantly looking at a nationally representative sample at what the case rate is. The latest ONS survey, published on Friday, does show a rise can summit, with the increased number of tests that have come back positive." He did not answer Sir Desmond's question, but instead answered a question of his choosing. Did the health secretary knowingly mislead the House by referring only to ONS and not even mentioning the false positive rate of the test in Pillar 2? He was, as it were, stealing the garb of ONS's more careful work which has a lower false positive rate, in order to smuggle through the hidden and very much higher false positive rate in Pillar 2. The reader will have to decide for themselves. Pillar 2 testing has been ongoing since May, but it's only in recent weeks that it has reached several hundreds of thousands of tests per day. The effect of the day-by-day climb in the number of people that are being described as cases cannot be overstated. I know it is inducing fear, anxiety and concern for the possibility of new and unjustified restrictions, including lockdowns. I have no idea what Mr. Hancock's motivations are, but he has and continues to use the hugely inflated output from a fatally flawed Pillar 2 test and appears often on media, gravely intoning the need for additional interventions, none of which, I repeat, are proven to be effective. You will be very familiar with the cases plot which is shown on most TV broadcasts at the moment. It purports to show the numbers of cases which rose then fell in the spring, and the recent rise in cases. This graph is always accompanied by the headline that so many thousands of new cases were detected in the last 24 hours. You should know that there are two major deceptions in that picture, which combined are very likely both to mislead and to induce anxiety. Its ubiquity indicates that it is a deliberate choice. Firstly, it is very misleading in relation to the spring peak of cases. This is because we had no community screening capacity at that time. A colleague has adjusted the plot to show the number of cases we would have detected had there been a well-behaved community test capability available. The effect is to greatly increase the size of the spring cases peak, because there are very many cases for each hospitalization and many hospitalizations for every death. Secondly, as I hope I have shown and persuaded you, the cases in summer and at present, generated by seriously flawed Pillar 2 tests, should be corrected downwards by around tenfold. I do believe genuine cases are rising somewhat. This is, however, also true for flu, which we neither measure daily nor report on every news bulletin. If we did, you would appreciate that, going forward, it is quite likely that flu is a greater risk to public health than COVID-19. The corrected cases plot, above, does, I believe, put the recent rises in incidence of COVID-19 in a much more reasonable context. I thought you should see that difference before arriving at your own verdict on this sorry tale. There are very serious consequences arising from grotesque overestimation of so-called cases and Pillar 2 community testing, which I believe was put in place knowingly. Perhaps Mr. Hancock believes his own copy about the level of risk now faced by the general public. It's not for me to deduce. What this huge overestimation has done is to have slowed the normalization of the NHS. We are all aware that access to medical services is, to varying degrees, restricted. Many specialities were greatly curtailed in spring and after some recovery. Some are still between a third and a half below their normal capacities. This has led both to continuing delays and growth of waiting lists for numerous operations and treatments. I am not qualified to assess the damage to the nation's and individuals' health as a direct consequence of this extended wait for a second wave. Going into winter with this configuration will, on top of the already restricted access for 6 months, lead inevitably to a large number of avoidable, non-COVID deaths. That is already a serious enough charge. Less obvious but, in aggregate, additional impacts arise from fear of the virus, inappropriately heightened in my view, which include damage to or even destruction of large numbers of businesses, especially small businesses, with attendant loss of livelihoods, loss of educational opportunities, strains on family relationships, eating disorders, increasing alcoholism and domestic abuse and even suicides, to name but a few. In closing, I wish to note that in the last 40 years alone the UK has had 7 official pandemics: AIDS, swine flu, CJD, SARS, MERS, bird flu as well as annual, seasonal flu. All were very worrying, but schools remained open and the NHS treated everybody and most of the population were unaffected. The country would rarely have been open if it had been shut down every time. I have explained how hopelessly performing diagnostic test has been, and continues to be used, not for diagnosis of disease but, it seems, solely to create fear. This misuse of power must cease. All the above costs are on the ledger, too, when weighing up the residual risks to society from COVID-19 and the appropriate actions to take, if any. Whatever else happens, the test used in Pillar 2 must be immediately withdrawn as it provides no useful information. In the absence of vastly inflated case numbers arising from this test, the pandemic would be seen and felt to be almost over. Dr. Mike Yeadon is the former CSO and VP, Allergy and Respiratory Research Head with Pfizer Global R&D and co-founder of Zyreco Pharma Limited.